At The Nocturnists, we are careful to ensure that all stories comply with healthcare privacy laws. Details may have been changed to ensure patient confidentiality. All views expressed are those of the person speaking and not their employer.
As doctors, sometimes we see ourselves in our patients, or we see our patients in ourselves. Sometimes this can be a good thing, a portal to empathy, but other times it can feel maladaptive, like it leads to bias and distraction in our work. I'm Emily Silverman, and this is The Nocturnists. Today's episode features Sirisha Narayana, a hospital medicine physician. In this story, Sirisha talks about her strong identity as a physician and how it collided with her other identities until one of her interns made a simple observation in the hospital. In the interview that follows, we continue to explore the topic of balancing our various identities and how we connect with patients differently based on them. It was a pleasure talking to Sirisha, and I hope you enjoy her story and our conversation.
So after my parents got married in India, the first place they arrived in the US was State College, Pennsylvania, where my dad was beginning a faculty appointment in computer science at Penn State. My mother did what any lonely, determined young woman in a strange new land would do. She found the phone book, looked up every single Indian name, and called each and every one of them, searching for friends. Pretty soon, we had built our own community of Indians in this small town. At my first birthday, 100 people packed into my parents' tiny one-bedroom apartment to celebrate. Life eventually brought us to the Bay Area, where all of South Asia likewise seemed to have descended. I was surprised to see the number of brown-skinned, dark-haired kids at school. It may have been because of this that I never had this classic identity crisis, so to speak. To me, I was just like all the other children around me. I spoke Telugu as well as English at home. My best friend spoke Hindi and English. I took South Indian classical music lessons. Half my friends were in Chinese school every Saturday morning. I went to India during summer vacation to visit my relatives. My friend Zeev went to Israel to see his. I was different, but all my friends were similarly different in their own cultural upbringing. I found security and, honestly, pride in my difference. I was uniquely American by being Indo-American. Now, of course, over time, my identity has changed. When I was little, I also strongly identified as an only child, probably because I wasn't very happy about it. In fact, I once lied to my kindergarten teacher and told her I had a younger brother named Sandeep. I picked a name very true to my Indian heritage, to be as believable as possible. But, obviously no one saw him because my mom left him alone at home a lot, all the time. That did not go over very well. When I went to med school in Chicago, I developed a deep association with being from the West Coast. And as I marched through my 20s, I saw myself more and more as a woman, which seems obvious, but was actually more of an evolution. And I think this was because I was dealing with life's nuances that seemed to align best with the strong female voices that were around me. Now, I still identify as being an Indian, but life has allowed me to choose who I want to be when I want to be that person. Then I became a doctor. Very quickly, I started living and breathing this profession. And it's not just the years of training or the hours we spend at work. It's the language we speak. It's how we think, how we feel. And it just doesn't turn off that easily, right? It creeps into bizarre aspects of everyday existence. My unusual ability to eat standing up anywhere, my impatience with inefficiency, my instant conversational comfort with other doctors. Many of my other identities have now actually become secondary. One day, I was taking care of a patient whom I'll call Shukla Jain. Ms. Jain was admitted with a urinary tract infection, and she was pretty confused. She wasn't particularly responsive, despite us rubbing her sternum and screaming into her ear. My intern, a young woman of Indian descent, paused for a minute before approaching her. Then she very calmly shook her arm and said very assertively, "Auntie." Auntie. Now, why would my intern call this elderly female patient auntie? Well, in many cultures, including in South Asia, older men and women are referred to as uncle and auntie out of respect. It's one of the most second nature parts of my existence as an Indian to say, "Yes, auntie," or "Thanks, uncle," or "No, auntie, I don't want any more food. I've had enough." I just don't even think twice about it. But I was still surprised to hear my intern call this woman auntie. I mean, the identity I had placed upon Miss Jane was that of patient, not that of older Indian woman, even though she was both, right? Granted, I did feel uncomfortable calling her Miss Jane. That felt foreign and formal to me. Shukla ji or Shukla auntie would have been far more appropriate in any other circumstance. I gave my intern a quizzical look. She looked at me and said, "What?" It's probably comforting to her. My intern tried again. "Auntie." And that's when Miss Jane turned to my intern and said, "What?" I mean, I was floored. This woman, for whom screaming into her ear was inadequate in rousing her, actually responded to my intern calling her auntie. I mean, my intern was probably right. She probably knew she was amongst her people. A couple months later, I took care of another Indian female patient who was also pretty confused. And this time, I tried my intern's trick right off the bat. I called her auntie. And yeah, she responded. Far better than to a sternal rub. The best part was that my entire team started calling her auntie. All 4 tall white men. All of them. Then last year, I took care of an Indian woman with a kidney transplant, whom I'll call Bhanu. Bhanu was transferred to our hospital for a higher level of care. And within hours of arrival, she developed fluid shock, and we had a really hard time figuring out what was going on. She just kept getting worse and worse every day. Her son, Ravi, probably in his 50s or so, was commuting between her bedside and that of another sick relative on the East Bay. The auntie trick didn't really work very well for Bhanu. I mean, she was pretty out of it the entire time. My last day on service, Bhanu coded in our ICU. I called Ravi early in the morning and begged him to come to the bedside. He didn't seem all that surprised. I mean, she'd been sick for a while. Perhaps he was expecting it. Ravi showed up, and we changed her code status to DNR, knowing full well that our options were limited in prolonging her life. I admit I was distressed about this patient. I thought she was far sicker than she should have been. I was worried that we were missing something. I was irritated with Ravi for being somewhat absent, but everyone agreed on the plan. As we watched her heart rate and her blood pressure drop, we each slowly filtered out of the room. I lingered for a bit outside her room and watched Ravi, who had been impassive this entire time, wanting to know what he would do. He looked at her, brushed her hair behind her ear, held her hand, and then he said one word to her, "Amma." I felt the wind rush out of me. Amma is the word I use to refer to my own mother. I teared up as I started transposing the face of every Indian woman I knew onto Bhanu. They were all ammas, in the way Bhanu was an amma, just as my mother is an amma. I have a hard time taking care of Indian women because of what I call the amma factor. It's their age and their tendency to look at me, their doctor, as a young Indian woman, a child really, not all that different from their daughters, and me to look at them as older Indian ladies, aunties and ammas alike. It's in these times when I can't consciously separate my different identities that I'm reminded that I'm a human with a history of my own and a background of my own. And it's here that I can actually prevent these identities from completely overtaking another. Because yeah, I am a doctor, but I was and am a great many things more.
So thank you so much for coming over to chat with me about your story.
Well, this was great. Thanks for having me.
Yeah. So in your story, you describe that one of the challenges in practicing medicine for you is to work with older Indian women, mothers and aunts, or ammas. Am I pronouncing that right?
Yes, that's great. That's perfect.
And you call this the amma factor. Have you found a way to manage the amma factor in your practice, and does it still pose a challenge for you?
That's a really good question. Yes, it still poses a challenge for me. I think we all as clinicians, all of us probably have some type of patient, of person that strikes a chord. For me, it just so happens that is one of the type of patient persona that strikes a chord. And I kind of hope it always does strike a chord, because it's like a constant reminder of that side of me. I don't want to become numb to it. So whether or not I've managed it, I think I recognize that it's a point of just the tiniest bit more anxiety or the tiniest bit more emotion. And that in and of itself, I think, is okay. I don't know if I want it to change much beyond that.
That makes sense to me. It sounds like dealing with patients who remind you of yourself or of your family is a challenge, but that's not necessarily a bad thing.
Yeah.
When do you think it is good or bad to see ourselves in our patients?
I think that can happen at the same time. You see yourself in your patient, but then if you get lost in that, if you can't separate yourself from it, if it drags you down emotionally, if you can't think objectively, I think that's a challenge. That's often why, as clinicians, we pause if we were to, cross any kind of boundary. Taking care of family members, for example, or friends is something that professionally we may or make a very conscious effort to not cross that boundary. But sometimes it's just inevitable. So it's hard to tease those apart, but I think recognizing it is the first step, and really just always being that check on yourself. Like, are you still practicing objective medicine? And are you able to, we spend so much time compartmentalizing medicine and setting boundaries. And the other side of this, and probably the more nuanced, reflective side of this, is knowing when it's okay to blur that just the tiniest bit.
Mm-hmm. I'm just trying to think of examples of times when I've run into a similar experience, seeing myself in a patient. And I have to say that I don't have, I think, as strong a connection with my ethnic background as maybe you do with yours. Not only am I white, but I'm also adopted. So I don't really have that like bloodline connection to my past. Mm-hmm. I think that maybe others do. I am Jewish, and so occasionally I'll have patients read my name tag and they'll say, "Are you Jewish?" And I'll say, "Yes, I am." And mm-hmm. usually they'll say something positive like, "Well, that means I can trust you," or something like that.
Yeah.
But I can't say that I've felt that different taking care of patients who are Jewish than those who aren't. Mm-hmm. I think in part because it's kind of hard to know if they're Jewish or not unless it comes up in conversation. I have had experiences taking care of patients who suffer from diseases that I have experienced through seeing people in my family suffer mm-hmm. from those same diseases. And that's, I think, probably the closest that I've come to experiencing what you talk about in your story. There's somebody in my family who suffers from Parkinson's disease. And anytime I work with a patient with Parkinson's disease, I sort of impose that family member's face onto the patient.
Yeah.
And it does color the way that I interact with and think about the patient for sure. And I think probably for the better.
Mm-hmm. I had a mentor once tell me in med school that he became more empathic as a physician as he grew older. And I think so much of that is as you gain different life experiences, you develop different connections to patients as they bring to light different sides of things. Mm-hmm. Same thing with different identities you probably adopt over time.
I went through a health issue of my own last year, and that's actually become part of my identity in a way. And when I'm dealing with patients who are suffering from ailments that maybe are similar and maybe aren't similar at all, but just having gone through that health issue, I know what it's like to have a surgery. I know what it's like to come out of anesthesia confused and not to know what had happened. And so that identity, I think, actually does function as a tool that I can use to help me take care of patients in a way that's better.
Has it translated yet into your patient care?
It really has. I think about chronic pain a lot differently than I used to because of what I went through.
Yeah. Do you talk about it with your patients?
Occasionally. In the clinic setting, which I don't practice in anymore because I too practice alone in the hospital. The issue I went through, thank God, was not a life-threatening issue. It was more of an outpatient issue, even though it did entail a surgery. And when I came across young women in the clinic who had the same disease that I had, I would sometimes say, you know, I actually have this disease as well, and this is what I recommend.
Yeah.
And I don't know if patients like that or dislike that, but I sense that they might like that. They might like that their physician is forging that connection with them.
There's this Nelson Mandela quote, which I'm thinking of because I read Trevor Noah's book where he quotes this quote. So I'm triple quoting this quote. And I'm going to botch the quote right now. But to summarize it, he mentions that you can, you know, if you can tell someone to do something in a shared mutual language, and then you'll get to their head, you'll get them on board. But then if you meet them in their language, that's when you actually get to their heart. That's when you really buy their support. So it makes me think of that, and also the discussion about identity is kind of similar in that same way. But the language can be many different things.
Right. It can be literal. It can be as simple as making sure that you use an interpreter who speaks Tagalog with your Filipino patient, or it can be more metaphorical.
I mean, it even translates to my own personal life with my family. My relationship with my grandparents is different because I grew up speaking our mother tongue. I grew up speaking Telugu. So with them, even though they knew English, it's a whole other relationship you develop compared to other members of my family for whom their language skills weren't as strong, and they didn't have that same connection. It's just it's so evident in so many different ways. But I like thinking about that a lot.
You mentioned in this story that these women that you take care of, these older Indian women, remind you of people in your family, like your own aunties and even at one point your own mother, and how that had a really strong impact on you. And I'm wondering, have you shared this story with your family?
My cousins were in the audience for the first taping. And my cousin's wife is due to deliver their daughter, my niece, today, actually. And his wife, because she was pregnant, because she was adopting the Amma role herself, I think it really resonated with her as well. I haven't shared it with my parents. And I don't know why I haven't shared it with them yet. I think because it's so personal. But I'm excited to. I think I'm just waiting for the right opportunity for them to hear it and listen. And I would just be so curious as to what they would think.
And remind me, is anybody in your family a doctor, or are you the only one?
I have an aunt who's a doctor and 2 other cousins who are doctors. So my family's familiar with the training that goes into being a doctor. But I think their conceptualization of, at least my parents' conceptualization of what a doctor means, I think is part of the challenge that I have with the doctor identity. We'll have family friends that come by and just really want to ask me questions. And my parents will offer me up as, go talk to her. They just want to talk to somebody. You can say something like, actually, it's not how that works. I don't know anything about this bizarre disease that somebody else has. It's not my area of expertise. But they have this very old school idea of what a physician is supposed to do. I remember in med school, as I was graduating, my dad told me a physician should bring people hope. A doctor should bring people hope. And I think about that so much because, he talks about his family doctor and going to see his doctor, and half the time they don't really do it. He's just a relatively healthy guy, so not that much going on. And he comes back feeling mildly dissatisfied. He's like, I don't know, why did I go and see this guy? Nothing's going on. And he just has this image of my role as a doctor as having that hopefulness, that comfort, that guidance. And I think we often question as to whether that's what we do in medicine. Sometimes we do that, but oftentimes we're there to bring reality too. So it's very interesting to see that juxtaposition of this image versus what the reality in our practice really is.
Right. It seems like with health and illness and medicine and mortality, there are a lot of deep philosophical questions that come up along the way, even existential questions about what it means to live a good life, or, what is death and what happens after death. And a lot of these questions over history have been relegated to spiritual figures in communities. But then with the emergence of modern medicine, it seems like the doctor may have some role in helping patients navigate those questions, but it's also really difficult because no one has the answers to those questions.
Right.
Do you have any other examples of a time where you weren't able to get through to a patient because of cultural differences? Maybe the situation wasn't that they were of a similar cultural background, but that they were from one that was so different from your own that it made the interaction hard. Is that something you ever run into, and how do you deal with that?
Yeah, I think we deal with that all the time in different forms. I could give the example of, a patient for whom cultural background prescribes that the patient themselves is not supposed to hear critical medical information. It's just the family and has to go through the family, which I think feels uncomfortable to me as a provider because I want to be able to converse with my patient, prioritize that patient. That's one example. Some language barriers that come up. That's another example. We, at the risk of being mildly controversial, I think we in medicine run into the conflict between what we believe to be reality and the most practical outcome, and what for many patients is a very, very deep belief that despite all odds, that patient, that family member, that loved one is the exception. And despite any kind of scientific information, there is some power that's going to have that person beat those odds. And I think that's life. And I think if I were those patients in those particular cultural upbringings, I would probably think the same way. And I think that is what has taken the time and space to just actually really try to be or put yourself as much in that patient's position. Like, what would I think if this was my father who was dying in front of this doctor? What would I want for him? Yeah, definitely I would want to believe that my dad can beat all those odds and a miracle would happen for my father. And I think that's how I'm able to cope. That doesn't mean it's not frustrating. It is frustrating because at the end of the day, I'm also trying to do my job, which is to be a physician and try to help them through and do what I think is the best for those patients and use my clinical expertise. But I think that's just part of taking care of humanity. That those are humanity's nuances that we have to learn how to cope with that.
Yeah, it's always a difficult tension, that tension between the realistic statistical odds and then what your father said, that the physician's job is to inspire hope.
Yeah.
And is there ever a point where we shouldn't inspire hope? I'd like to think not. I think that we should always try to inspire some sort of hope. Maybe it's not hope for another 10 years if that's not realistic, but hope for something, hope for some sort of something to latch onto that maybe is within the bounds of what's realistic. But it's definitely hard to navigate, especially when you're dealing with ways of thinking and cultural beliefs that may differ from that of your own. In your story, you touch on how you have multiple identities. So, for example, you identified when you were a child as an Indian child, just the same way as your friends identified as Israeli or what have you. And then you talk about how when you grew older, you started to identify more as a woman and then later as a doctor. Can you just talk about those different identities, and do you see them as distinct or do you see them as superimposed, or how do you, in any given moment, do you feel like them all, or do you feel like just one, depending on what you're doing, or what does that feel like to you?
I think I would say it's almost a tier and a hierarchy in some ways. There are going to be times where I feel much more bound to my Indian identity. Oftentimes that's when I'm with my family, for example. And other times I'm going to feel much more bound to my physician identity, or my identity as a friend, or my identity as a kid who grew up in the Bay Area, or the other identity I talk about in the story is that of an only child. It just depends on the circumstance. I don't want to lose all those identities. I'm realizing that now more as certain identities become stronger. And I think that's what I mentioned a little bit more in the story too, is as I become a physician, that has been a very powerful force, to the point where sometimes I feel like those other identities are stifled a little bit more.
So backing up to your story, that initial moment where the intern leaned in and said, "Auntie," what did that moment feel like to you?
I was like, I think my exact thoughts were, what are you doing? Why are you saying this? I was so thrown. And it was just so jarring to see that brought to a patient room in the hospital in my professional environment. But I also thought, oh, this is so cute. Look at this like wonderful intern that I have who's trying to use her background. And I felt very maternal at that moment, and very proud of her for really trying to think outside the box. And I really did. I really did just try to do that with all these other patients in the same way. So good for her.
Good for her.
Yeah.
You should give her a anonymous shout out
if
she's listening. Any lingering, burning revelations that you want to share?
No, I mean, the opportunity that you've provided, Emily, for us to share these stories is so meaningful, and I can't thank you enough for that opportunity.
Thank you. It's my pleasure. Super interesting conversation with Sirisha Narayana. Thanks so much for coming in. And thank you, audience, for listening to The Nocturnists. As usual, if you like the show, please subscribe and circulate our information to your friends, family, and colleagues. And don't forget to rate us on iTunes. Thanks to our podcast producer, Marina Poole, executive producer, Ali Block, our intern, Celine Ross, and Yosef Monroe and Blue Dot Sessions for the music. I'm your host, Emily Silverman, and thanks for listening.